Very good. So, Kim, I think your mic is muted, but I will make an introduction very quickly. Well, we are very pleased to have Dr. Pomeroy. He is the scientific director for the World Health Bank. He has lectured at many scientific meetings and postgraduate courses, and he is a co-author for a number of papers. He has served as a member of SARS Executive Board Chair of the Reproductive Laboratory Technicians. He is also a chair of the College of Reproductive Biology and founder and member of the Regulatory Task Force and the Southwest Embryology Summit. SWES was a total success. I congratulate you for that effort, Kim. With this, I will give you the floor. Thank you so much for your participation, Kim.
Thank you very much, Nabil. I've just got to say, I was very impressed with your lecture. I learned a lot, as I'm sure all of us have, and I hope that a lot of embryologists will get onto this site and that we're able to make it today and see it later, because there was a lot of information there that was very interesting, and I think can help us in the laboratory from day to day.
Thank you so much.
All right, let me go on and see if I can forward my slide. I'll go back here. So what I'd like to talk about a little bit today is how to maximize bank donor ova pregnancy rates. And I'm going to talk about what are called Cinderella embryos and other factors. I'd like to remind everyone that I am the science director for the World Egg Bank, but I've also been a lab director and continue to be an offsite lab director at other clinics throughout the US and the world. So I am not speaking just from the standpoint of the World Egg Bank, and I hope you'll find this lecture interesting. I want to also mention that some of this lecture is based on an article published by Dean Morbeck in Human Reproduction. And he gave a great lecture a few years ago in Adelaide at the FSA meetings. And his article was really interesting in that he said, we need to relook at the embryos that we decide to vitrify and discard. And maybe we haven't changed our protocols and we should revisit them. So let me ask each of you a question. What will you do to get one more patient pregnant? I know most of us, we do almost anything. It may only increase your clinic's pregnancy rate a little, maybe only 5%. But think of how that one patient will feel if they are given that extra chance. I know at Lucinda Veek, who we all know, what she did to increase pregnancy rates. She would come in at all hours of the night to do her flat bottoming of oocytes to check maturity, to make sure she got every mature oocyte, even if they matured after collection. Will we spend that amount of time to help our patients? I should mention that what is keeping you from getting that one patient or even a few patients a year pregnant is most likely found in outdated policies. Policies made before vitrification was common. And if you don't take the time in your already busy schedule to examine these policies, these patients will go home without a baby and with the same pain that they had for years. All too often we do things and we fail to re-examine them in light of new methods and technologies. So I want you to spend some time and re-examine in this lecture how we select embryos for transfer and freezing. And also we're going to look at factors that affect vitrification and warming. Let's see, did that change the slide there? No. Okay. So I'm sorry here, I'm trying to flash between slides. So here's a slide I want to show you. If you look at the data on the left, I've chosen to compare 2 years, 2003 and 2013. And the reason I chose these 2 years is there was not a lot of new technology. PGTA at least hadn't really started in most labs by 2013 to be used a lot. So this is a good year. These are 2 good years to look at live birth rates from fresh from fresh embryos and live birth rates from FETs, or frozen embryos. If you look on the left, between these years, there's not much a difference between 2003 and 2013 for live birth rates for fresh embryos. But look at frozen. There's this big increase for frozen embryos in almost all age groups except maybe greater than 42. And I would say that this is due to the advancement of vitrification. And vitrification then has gone on and helped us to increase our pregnancy rates and how we treat our patients. Now, here I want to look at two separate clinics. So A is a very large clinic. They have a very in-control laboratory. Warming is restricted to only a few trained embryologists, maybe 2 embryologists for a large clinic that is doing probably 1,000 to 1,500 cycles a year. Like ICSI, warming skills can deteriorate if not used often. Now, Clinic B is actually fairly small, so some would guess that their embryologists should be forming better because they see more VIT cases per embryologist. Well, point here is that there are big differences in the ability of clinics to have a high pregnancy rate with vitrified ova. Some do well, some are okay, and as you can see in Clinic B, some are terrible. What's interesting about Clinic B is they started out with the first 6 cycles they had using vitrified ova were pregnancies, and then something happened. Why the discrepancy in the implantation rates here? 68% for the large clinic, 25% for the smaller one. And interestingly, they're using similar numbers of ova in this analysis. And the clinical pregnancy rate, 72% versus 14%. So we went back and audited Clinic B and found out that this clinic was not very controlled, that the embryologists had modified a lot of the warming protocols. They had reduced the volume of the warming media to save money. They weren't paying attention to timing, and they're using different dishes than what we had recommend without taking into account the handicap of those dishes. For example, excuse me, using a center well dish to warm oocytes, and these dishes cool down rather quickly because the bottom of the well doesn't touch a warm surface. So the warming of ova, we feel, and the ICSI of warmed ova is more of an art. It's a different type of technique than just going through and doing it blindly like a recipe. We also do less of this. We do less warming. We do less ICSI of warmed ova. And warmed ova tend to have a sloppy vitelline membrane, and they're a little bit more difficult to ICSI, I believe, and to do it without damaging the ova. Can you imagine how good you would be at ICSI if you only did 2 or 3 cases a year? Well, this is the case for many people in warming ova. And warming ova is less forgiving than warming blastocysts. Vitrified ova are less forgiving than fresh ova because of ICSI. So where do you find yourself in this level of success with using vitrified ova? And are you willing to spend some time to try to improve the rates that you have? Let's go on to the next slide. Now here's a very interesting slide. This is actually a comparison from one clinic that does very well. This happens to be IVFMD in Miami, and they use several egg banks. And here's a comparison of different outcomes with those egg banks. Survival rate, they all get about the same survival rate. Fertilization rate, very little variability. Then you look at percent of blasts produced. There's a wide variability there. And implantation rate from 80% down to just a little over 40%. And how many embryos are left over to vitrify or cryo, and then a wide variety in pregnancy rates. And as you can see, there's quite a bit of differences there. So point 3 I want to make is a good clinic that follows protocols for warming and has good endometrial preparation and good embryo transfer methods can have great results from eggs from any bank. a big variable in success are these clinic factors. Each bank has from 6 to 150 egg donation cycles in this chart. Now, can a clinic perform well with eggs from different egg banks? This laboratory and clinic has shown that they can. There are many similarities among these banks and some differences, but the most important is that their ongoing pregnancy rates are not below 50% with any of these banks. Where do you fit in with your experience? Can you always maintain at least a 50% pregnancy rate with using vitrified banked eggs? If not, then I think we need to find out what this clinic is doing that can help us all to have these rates. There are subtle differences among banks. There are sources of eggs that are different. Some where the banks, they harvest all the eggs, and some where they farm out those supplying of eggs, and they kind of act oftentimes like an egg bank that doesn't have any of their own eggs, but there are IVF labs that collect those eggs for them. Who's been vitrifying these eggs? How long has the embryologist been vitrifying? Is this a new person, or is this someone that's been doing it for a long time? I think some things are often missed as affecting the quality of eggs from an egg bank is how are the cumulus cells removed? Are they moved delicately or not? How long are they left out on the bench top in a non-perfect environment? We must have constant monitoring and reviewing of all the procedures because we know that protocol drift can occur, and it's important to decrease the variability in egg quality. I was trained by Michael Tucker and Jeff Boltz many years ago to do vitrification of oocytes, and I know that I had to vitrify and warm hundreds of eggs until the procedure was ingrained in my muscle memory and I felt proficient. We also know that temperature is of critical importance, and I can't overstress this. The temperature of the warming media, the TS media, we believe it should be between 37 to 38 degrees centigrade should be the temperature in the media in the vial. And for this reason, we feel that only a properly prepared water bath or a non-CO2 incubator should be used for warming. If you want to have pregnancy rates, but not very high pregnancy rates, go ahead, use a warm block, use a tube block, use your bench top. You're going to get pregnancies, but we're talking about how to have the highest pregnancy rates. How one warms the eggs will not influence survival rate though. So if you're looking and saying, wait, I have great survival rate, we have warmed eggs at room temperature. We have not seen any difference in the survival rates when we warm those eggs at room temperature. Let me go to the next slide here.
Hey, Kim?
Yes.
We don't see your presentation. Do you have any PowerPoint? Are you sharing your presentation?
No, it's coming from there. That must have just disappeared then. It was up there. So please reshare that.
Okay.
Riley, it must have disappeared from my presentation.
Can you share the presentation? Okay, let me do. Okay, let me share the presentation here. 1 second.
While you're working on that, Nabil?
Yes.
Did you guys see that last chart with all the different banks, egg banks being warmed?
We have seen that. Yes, the differences in outcome.
Okay.
And I'm gonna just jump to the next slide.
And I can kind of start explaining that slide before it shows up.
Sure.
So I want to show some things that we see that are non-donor factors in outcomes. I should mention, having a donor factor as related to a poor outcome is very rare. I think in the 8 years that I've been working with the World Egg Bank, we've maybe seen 5 donors that we suspect there may be a donor factor. We usually don't get enough data to be able to determine for sure, but we have seen cases where for sure there were non-donor factors, and that's what I want to look at right now. One way to look at the source of poor outcomes using vitrified eggs is to look at vitrified donor eggs where the lot is divided among different recipients. And this is very routine in egg banking. So one part of a cohort will go to one clinic and another one will go to another. So if there's a poor outcome and it occurs with all of the clinics, then one can assume that it lies somewhere, either in the donor, the stimulation, or the vitrification. If, on the other hand, the poor outcomes occur in one recipient at one clinic and not in others, one can conclude that the cause may be associated with storage, warming, embryo transfer, or something with the recipient. I started looking at 2 different poor outcomes with vitrified ova because they were easy to look at. One is poor survival of the eggs, and the other is poor fertilization. Now, if the cause of these events occurred prior to shipping, then one could assume that all recipients using the same lot of ova should have similar results. That's the correct slide there. Thank you. If the cause was after shipping, then the cause could be in the warming for survival, or it could be in the ICSI and warming for poor fertilization. So I looked at 300 cycles for those cases where the survival rate or the fertilization rate was 25% or less. I considered those poor cycles, and where lots of the same eggs were warmed. So I had additional lots from that cohort. I found 2 cases of poor survival and 3 cases of poor fertilization. So this was 3% of all the cases I examined. So let's look at first poor survival. Why is there this disparity? If you look at this difference here, I'm trying to make this just a little bit larger so that I can see. Well, if you look at this difference here, Clinic A had 0% survival. Nothing survived. The same egg cohort gave 66.7% from Clinic B, and they had a pregnancy. And Clinic C had 14% survival, while Clinic D had 71% with the same cohort of eggs and had a pregnancy. Next slide. So how can we explain this? I honestly don't know, to be honest with you. I have tried to replicate having poor survival, and the only way I can get it is by mixing up the warming media. But it appears not to be related to temperature of warming. We have even mishandled human eggs on purpose in an experiment by exposing those eggs to room temperature for up to 10 seconds with the caps off. And then we plunge them back into liquid nitrogen as if someone's made a mistake and looked at them and said, oh, I wonder what this is. And then go, whoops, and put them back in liquid nitrogen. And then we warm them up with the normal method that we use, and the survival rates are still acceptable. Next slide. Oh, I'm sorry. Could you go back, Nabil? Now let's look at 3 cases of poor fertilization. These ova were warmed at different clinics. The first case had 3 batches of eggs from the same lot, and you can see the results there. 0% fertilization, 83.3 and 50%, and one of them resulted in a pregnancy. The next case, there are 2 clinics with 25% fertilization and 100%, and the other one with 100% fertilization and 0% fertilization. So in these 3 examples, not only were there very good fertilization, but there were even pregnancies. These batches of eggs were 6 or 7 eggs, and when poor fertilization was discovered, there was no data that we could find to indicate there was an issue with the particular donor. And you can see here why we could see that is because there was good fertilization rates from other batches. So what do you feel could have caused these reduced survival and fertilization rates? Many want to blame the egg quality, the donor, the person that did vitrification, but this data does not support that opinion. I feel that sometimes some of these poor results of fertilization or even embryo development are the result of too rough of ICSI. And it's very difficult with this sloppy membrane that you sometimes get to have to feel comfortable with the ICSI because we don't do it that often to eggs that have a sloppy membrane. So the skill set for ICSI may be different for fresh eggs than for vitrified eggs. Next slide. So we've talked about the importance of temperature to success in warming, but it does not necessarily affect survival rates. Fertilization rates are affected by how ICSI is performed, in which term it's affected by the sloppiness of the egg membrane. Now, if you don't do a great ICSI, you're not going to have very many embryos when you start with 6 or 7 to then develop into blastocysts. We can see from the second slide that I showed that there are what may be called super labs that somehow do it all right and get great results no matter who supplies the ova. Still, there are some egg banks that can have improved results by reducing inherent variability in their system, how cumulus cells are removed or how eggs are vitrified, for example. Despite all these variables, here's what one can expect from a cohort of 6 to 7 ova. What's interesting, I've done this analysis twice, and I get almost identical results. So if you look at this, about 5% of cases result in no embryo for transfer. It's not the fault of the donor. It's not necessarily a lab fault. It's that for unknown reasons, when you have 6 eggs and they have to go through survival of warming, fertilization, development into a blastocyst, sometimes you only get about 5% where you have nothing that produces a blastocyst. And then as you look across there, you can see you go to 24% that will produce 1 blastocyst, 34.5% that produce 2 blastocysts, etc. If you look at it, you can see there's a high percentage that will produce 2 or greater blastocysts. And that's what we like to see. But it doesn't mean you're always going to get that. Sometimes you will be in that 5% part where you get no embryos that develop to blastocysts for transfer. So now I want to look at, we've made embryos, and what we do with those embryos is now very important. So next slide, please. These are what I call Cinderella embryos. These are the embryos that don't meet the normal standard for transfer, or at least your protocol, because they look a little ragged on the outside. They're discarded instead of being frozen and are transferred. These embryos are grubby looking. They include poor morphology embryos, slow growing embryos that might be delayed in development as much as 24 to 36 hours, and blastocysts without a discernible ICM. These embryos seldom get invited to the ball. They're often not transferred nor vitrified. What may affect your decision not to transfer these embryos? What implantation rate would make them not worthy of transfer? 20%, 10%, 5%? Have you determined that these embryos produce those rates in your system? I would guess we should also ask, what would your patient say was the lowest acceptable rate? Let's quickly look at what happens if these embryos have a fairy godmother that allow them to be transferred. Next slide. First, I'd like everyone to look at a series of embryos, including this embryo here. These embryos did not look very good. They were mainly early blastocysts, not full blastocysts. Now, these photos of day 6 show that they won't win a beauty prize. So what would you do with these embryos in your system? What does your protocol dictate? What if they were the only embryos that you had to transfer? Would you handle them differently than if there were 3 great-looking AA blastocysts and this was the remaining 4th one? And why would you treat them differently that way? Next slide. So what are you going to do with these embryos? Next slide. So these embryos are, thank you. These embryos are not only poor embryos, they are also slow developing embryos. A lot of people would discard these embryos. Next slide. And these are what I call Cinderella embryos. It's time for a poll. What is your clinical laboratory policy on these type of embryos, on poor blastocysts or slow developing blastocysts on day 6? And I must say, I know there are some poor blastocysts where you can see they're not really blastocysts. It may be a 5-cell embryo, and one of the cells appears to form this big vacuole and appears to think it by itself as a blastocyst. Now, I'd like to have you ask yourself, why do you have this policy of discarding these embryos? Do you have data to support that the pregnancy rates are so terrible for these poor, slow-developing blastocysts? Are these embryos aneuploid, or do they develop into unhealthy babies? Next slide. Here are some embryos that are not necessarily slow developing. They're just poor. Very little trophectoderm, poor looking ICM, or even no ICM. It's bothered me for years, even more so since we began doing vitrification, that progressing, poor, or developmentally delayed embryos are often discarded. In most research studies, and I believe this is where people got their criteria of what to transfer and what to vitrify, only stage 1 and 2 embryos are not included, as are any blastocysts with a C grade for vitrification or for transfer. So how has this all of a sudden become the standard of selection of embryos to discard? Whether this is due to an oversight or an effort to demonstrate higher pregnancy rates, I don't know. I've always been of the opinion, though, that any progressing embryo should either be transferred or frozen. It does not matter whether one has 2 embryos or 15 embryos, they should be treated the same. But often poor embryos are not transferred, frozen, or biopsied. I've identified several instances in the analysis of my data at work at the World Egg Bank where a recipient using donor eggs had only poor blastocysts to transfer. Rather than take the chance and transfer them, they're discarded per the laboratory protocol. And I have many more instances where poor donor egg-derived embryos are not vitrified after transfer. Most likely, this protocol to discard poor embryos was developed without any knowledge of implantation rates for these embryos. And it was either assumed the cost of the transfer and the vitrification or warming wasn't worth it, or that these transfers would affect the clinic's public fresh pregnancy or FET rates. Now let's have a frank discussion with this patient that produced these embryos. Mr. and Mrs. Brown, you've got 1 great embryo to transfer, and we have these other 2 embryos, but they're terrible, and we're going to discard them. Now ask yourself, what was the possibility that either of these 2 embryos, A or B, would produce a viable pregnancy? Would you be surprised if I told you that both of these embryos produced a live birth? And what are the blastocysts that look so pretty, but you can't see an ICM? Have you ever marked a day 5 or 6 embryo as having no ICM, only to look the next day and behold, there's a developing inner cell mass? With the enormous expense of banked donor ova, I think it's a waste to not give every progressing embryo a chance to implant as long as a chance to implant by either transferring it or vitrifying it. I don't think we have a crystal ball that we can predict which ones won't implant. And I can tell you that the better clinics that I've seen will give these embryos chances to implant. Next slide. Now let's look at delayed development. I want to look at data. I'm going to go through these very quick, but you can go back later and look at these slides and look at the data. Here's a slide of what happens with day 7 cryopreserved embryos. So these weren't normal developing embryos, but they're still vitrified. You have to realize this from 2006. This is prior vitrification. So a day 5 and 6 pregnancy rate of about 20% is pretty good. And the day 7 with these slow cooled embryos is 11%. So is having a half the rate of implantation not worth it? And should we discard these embryos? I think that we need to re-examine what we do. And let's go on to the next slide. This is another study, and this is a day 7 embryo transfer study. It's by Kovalevsky. This involves 1,406 embryos, and they indicate excellent results with day 7 vitrified embryos, despite transferring them all on day 6 of progesterone. Is 26.7% too low of a pregnancy rate to consider the culture and vitrification of day 7 blastocysts? Let's go to the next slide. Once again, another study. I hope I'm driving home this point. This is Hiraoka in 2009, vitrified and embryo transfer of about 250 blastocysts. These are all on day 5 of progesterone. And there's no difference between the day 5, 6, or 7. I'm sorry, we're on the wrong slide there, but that's okay. Let me take a look here and see where. Yeah, it's one back, but still, there's no difference in the pregnancy rate. Now, in this one, we're looking at the study by Bouillon, and they looked at the potential of poor blastocysts. Here's a comparison of live birth rates for good versus poor blastocysts. This is the transfer of a single embryo. So would you discard an embryo that would only give a 34% chance of pregnancy, those poor blastocysts? Next slide. This is also from the study of Bouillon. Next one. And it indicates that poor embryos have a lower, go back one, have a lower pregnancy rate, as do slower developing ones. But even the poor embryos that are developing slowly have a pregnancy rate that is about half that of good and excellent embryos. Once again, this is Bouillon 2017. Next slide. And this is Goto in 2001. These were 1,488 cycles of FET, day 5 progesterone, single embryo transfers. And you can see here that even slow embryos and slow poor embryos have a pregnancy rate, depending on age, that's acceptable. If you look at that one, age 34 to 37, 11%. So I've shown you several studies that show poor blastocysts and slow developing blastocysts, and even poor slow developing blastocysts have acceptable pregnancy rates. So I think we should all re-examine. Remember our discussion with Mrs. Brown? Now what if we went up and we said, Mrs. Brown, you've got one great embryo transfer, nothing else was suitable for freezing. The other 2 embryos, they were poor and they only had a 35% chance of producing a live birth. So we're going to discard them to save you some money and time. What do you think their response would be? I think that response was shown in the prior one, right there. Next slide. So I think what we need to do is rank embryos as we've been told to do, but we should transfer freeze all progressing embryos. Don't discard embryos due to lagging in development or because they're poor. Forget what your statistics say and do what's right for your patient. I know that there's some issues with a biopsyable embryo or not. And so for that reason, I don't believe we should be doing biopsies of donor embryos, embryos from donor eggs, because sometimes you will find that maybe an embryo hasn't developed enough and you don't feel good about biopsying that embryo, that you might damage it. And therefore you're going to discard an embryo that in all reality has a very good chance of being normal. Next slide. The one thing that we haven't talked about, and I will leave you on your own to discuss this, is what to do with 0PN and 1PN embryos. How do we know if they're bad or not? Next slide. And you can come back and look at this later because there are several studies that look at the normality of these embryos. And we now know from videography of fertilized eggs that these embryos that have 0PN or 1PN, they may just be delayed in development of those PNs. There may be asynchronous development, but they can still develop into pregnancies and great embryos. At the bottom, you'll see Trounsyn as far back as 1999 and Danny Dassig back in 2004. Both had births from 1PN embryos. Next slide. The last thing I want to do is I don't want to leave out the physicians in this discussion. Endometrial preparation is critical and embryo transfer technique is critical. I think a lot of times in the past, we've heard that the endometrium preparation, whatever you do, doesn't matter. There have been studies that have compared and there's no differences. Those studies were not powered with enough participants to be able to show a difference. But there's been a recent study that has been done. Next slide. And if you look at this study here, this study was done and has shown, this was done out of Shady Grove, and they compared progesterone and oil to vaginal progesterone or to progesterone and oil with vaginal progesterone. And if you can see, pregnancy rates are fairly similar, but the vaginal progesterone by itself had many more losses. They used 50 milligrams of progesterone oil every evening. 200 milligrams of endometrium were used twice a day. And for the progesterone and oil plus vaginal progesterone, they gave the progesterone and oil every 3 days instead of every day. So you can make a difference on how you do your luteal phase preparation. One thing I would say is if you want to see how well you're doing, just go ahead and look at the SART data. If you have a pregnancy rate of either fresh donor egg cycles or your group of patients that are less than 35 years old, that is less than 50%, then there is room for improvement. And that improvement can probably be done in luteal phase prep or embryo transfer technique. Next cycle. So I would recommend reading Dean Morbeck's paper, Blastocyst culture in the area of PGS and freezols is a C, a failing grade. That's in human reproduction. And I think we need to decide if we're willing to change some of the things we do, spend time to look at what we are doing in our protocols to improve our outcomes. Thank you.